Healthcare and senior care is fraught with problems and challenges, but we're also seeing some amazing new clinical treatments and resources. This show will help illuminate and uncover the good, bad, the ugly in order to equip patients, families, and other healthcare providers. Welcome to Senior Care Confidential.
Happy New Year 2024. It's our first show, Senior Care Confidential. Hi, Brian. Happy New Year to you.
Yeah, thank you.
How was your holiday?
It was good. I got the touch of the flu. Sounds like you did too.
I did
It's
too.
been going around here in Dallas.
It has been going around everywhere. Stomach flu, COVID, just flu.
Yep.
And then RSV.
Fever for 4 days in my case, in my kid's case. Yeah.
My husband had fever for 4 nights too. It was over 100.
Yep.
And he was miserable. Anyway, no COVID though, so that was good.
It's good. Yeah.
I know. It was good. Great weight loss plan for the holidays.
That's right. That's right.
So anyway, so today we are talking about just the new year. And, you know, I've been following this story in the New York Times, dying broke. How are we going to pay for care for our seniors?
Oh, yeah.
And the story is just fascinating. And I think starting the new year, people are talking about finances, how to save, you know, what can we do differently? You know, how can we improve on our lives? You know, how can we make a change? And one thing, we have to start talking about the cost of care.
Yes.
So we're talking about,
and we're not talking the cost of healthcare. We're actually talking about the cost of what they would call like convalescent or caregiving care. If you're needing people to help you either in your home or you're having to move to a new home where caregivers live or work, that's the kind of cost that we're talking about here.
That's right. So the New York Times put out this story about the financial strain of caring for an aging loved one. One thing in this article it said, and I thought this was so awesome, financial ruin is baked into our system, whether you're rich or poor. Tell me your thoughts on that.
Yeah. So maybe I think so. I think for sure it gets much more costly, you know, as we get older. And then we'll talk about some stats in a second. But it seems like when you look these stories up, and even in our world working with elderly patients, it seems like the folks on the higher end of the wealth scale seem to be managing things okay, and then the folks on the lower end of the wealth scale seem to be managing okay because they're able to access like Medicaid and those kind of things. Where I find the most challenge is with the people who are like middle income or middle net worth. That's where they're in this messy area where they have too many assets to qualify for Medicaid, but they don't have near the assets available to them for things like live-in care or assisted living care or whatever.
Mm-hmm. It's very scary. So just talking about the cost. So we're going to start. The cost for assisted living, the average nationwide is $4,500 a month. Now, I just went with one of my clients and we've looked at 6 or 8 places in the last week, and $4,500 is on the low side. The lowest we found in Central Dallas, independent living, 2-bedroom that was decent. She could park her car, was $4,900.
Yep.
That was independent living, 3 meals a day. That's all you get.
And what's the average for a Social Security check?
Her
couple grand, 2,500, something like that?
Yeah, 2,300.
Yeah.
So you've got to look at her check's going to go straight to that half of that income.
Yep.
The other half has got to come from savings somewhere.
Yep.
Okay. So
or family.
That's right.
Yep.
Or family. So assisted living, $4,500 per month nationwide. Dallas, that is a little higher.
Yes.
You know, we're higher here. Skilled nursing, $9,000 to $12,000. I did check with a friend of mine who is with a big company community here in Dallas that has skilled. Their rate per month for skilled nursing is $14,000 a month.
Yeah.
That is buying a car, a used car.
Every month.
Every month.
Yep.
Private care, round the clock care is between $13,000 and $14,000 a month. So if we're going to have round the clock caregivers at $30 to $35 an hour, and you've got to include overtime, that is a huge chunk of money.
Yep. If you're just going to do it for like 40 hours a week, it's roughly $50,000 a year.
Yeah.
So it's like $4,000 a month if you're doing about 40 hours or so, give or take a week. but that doesn't include overnights.
No.
Right.
And that family that you were talking about that's in that crunch, the daughters that work full time and mom's living with them, but they've got to have a caregiver while they're gone, that 40 hours. Well, maybe the daughter makes $35 an hour as a teacher, but the caregiver is $32 an hour. So they're spinning their wheels on, working versus staying at home, quitting your job, losing that retirement.
Yeah, AARP had a study a couple years ago. And it says that they estimate between 26 to 40 million individuals spend part of their days or part of their weeks caring for an aging loved one. And annually, on average, they say that's between 16 to 24 hours of care per week.
Wow.
So you have, roughly call it 30 to 40 million people that live here in the United States that are committing to between or roughly 20 hours a week of unpaid caregiving help.
Well, I know with my parents, I'm a nurse. I have a business. I had a business, took care of my grandmother. Yep. Nobody in the family really stepped up. And I was a nurse, so I was and I didn't mind. I loved it, actually. My parents too, I had to work, and then paying for care. It's very expensive when you're paying for college and private school and insurance and, everything else. So anyway, it's a lot of money. And I think there are some assumptions that people have about long-term care. So let's talk about those assumptions.
I would say the number one is Medicare covers it.
That's right.
And Medicare is nothing but an insurance company.
That's right.
It's run by the feds, but it's still an insurance company. They do not cover what we call convalescent care. So if you're needing somebody to come out and help you, with dressing, bathing, light housekeeping, medical transport to physician practices or whatever, they're not covering that. And we get this question a lot. I thought Medicare covered home health aides. I'm like, yeah, it's very temporary though. It's not seen as a long-term solution. And so that's one of the big myths or one of the big misunderstandings rather that we have to correct often.
I think too with home health, one of the assumption is that home health services, as long as you don't want to go on hospice, you should be able to have home health indefinitely. So what is the average length of stay for someone that goes on home health through Medicare?
Yeah. So it's roughly, let's just call it 60 to 90 days on average.
So 3 months.
Roughly. Yeah. And it's usually, once or twice a week. Early on in services, we usually will have therapists and nurses seeing them more frequently because usually there's been some sort of incident. There's been an injury, there's been a fall, there's been an illness. And so initially we'll kind of what we call front load visits because there is some higher risk of them having another failure. And as time goes on, you'll see those frequencies reduce over time. But yeah.
Another thing, an assumption, you're seeing these commercials at the end of the year, the Medicare Advantage plans provide everything, including the kitchen sink. People even think they're going to get some kind of a long-term care program with that, and they're not. I know you and I talked about there are some that are.
There's some limited ones. I've seen them where like Aetna or whoever is authorizing, a few hours a week of some private duty in-home care, but it's pretty minimal. The other thing that we since we're talking about cost too, there's an assumption that a Medicare Advantage plan is going to save me money, and really, it's a flawed assumption because really what it is, it's more of a pay as you go. And so, yeah, if you're generally healthy, and you're not going to need to access hospitals or rehab hospitals or skilled nursing facilities or home health, then you can probably save yourself $120 to $150 a month by going with the Medicare Advantage plan over original Medicare. The downside to that is when you start to access or need to access that care, the costs can be well into the thousands. So you think you're saving, but you're really only saving money on the upfront. But once you start needing it, so we have a lady we were working with recently, and she has one of these Advantage plans, and unbeknownst to her, because she thought she was just getting a better. Because that's what they're told. This is just a better Medicare program. It's not. Medicare is one thing, right? Mm-hmm. These other programs, if you will, are controlled, or they're provided by commercial insurance. It's essentially commercial insurance plans that uses the Medicare dollars that you spend, right? And so she thought she just had a better, cheaper Medicare plan, and come to find out, she had a one of these Advantage plans, and her time in the skilled nursing facility was up, according to some utilization review person 3,000 miles away, and she was not anywhere near ready to go back home yet, and so she ended up out of pocket for the next, I think it was like 60 days or 45 days, and so it was like something like $17,000 that she had out of pocket. And then when she comes to the home health, she had I think it was a 40% copay. So by the time all is said and done, she's into this thing for $30,000, $40,000 that she was not expecting. That $30,000, $40,000 could have been very helpful in getting her some private duty caregiver help in the home. So like the insurance stuff that we're choosing as seniors too needs to be kind of calculated into, your overall cost, because, she thought she was saving a couple $100 a month and ended up costing her $40,000. So
I just don't understand why the government is not getting involved with that, because those Advantage plans are a scam. And so
I'd say they're a scam. I would say the vast majority of them are not good plans. And I shouldn't say it that way.
They're good if you're healthy.
They're good if you're, that's
and
right.
you don't have a lot of money.
Right. Or if you want to play the game of, I would rather have less cost up front and then just run the risk of, if I got to pay more, I got to pay more. Those are fine. Where I get really upset with them is in how they're sold.
I know.
I don't like them being called Medicare plans or a different version of Medicare, even though technically it falls underneath that. It feels icky to me, like it's a sleight of hand thing. And it really should be its entirely separate thing. It's run by commercial insurance plans. And if that's the route you want to go, fine. But be aware that these are the risk factors that go into those things. Mm-hmm. But, the other piece of it is, we've talked about this before, where there's, the regulatory capture piece of it, where they're just changing jobs. There's a lot of lobbying dollars that are spent in these things. You can't get congressmen to agree on anything, but they all agree that Medicare Advantage things are the bee's knees. Like this, come on, like there's nothing that we agree on in Washington, D.C. except for Medicare Advantage plans. So, there's a lot of money changing hands with these things. But all that to say, we've already talked about Medicare Advantage before, but it is a factor when we're talking about the costs of aging and the need for planning for additional costs as we need additional help in the home or whatever. The insurance choices that we make absolutely need to be factored into this as well.
I know. And, I've paid in. I've worked since I was 15. So I put myself through school. So I should have all these years of working. I should have a decent plan when I, services. Mm-hmm. Turn 65 and I fall.
They're talking about the Social Security stuff being,
I know.
Being in the red. And so, the amounts of money that you're seeing now for those of us that are younger, that's not going to be there as a backstop, or at least in the amounts that, we thought what might be there.
Mm-hmm. I know. So save your money.
Right.
Okay.
Or have lots of kids. That's the other issue too. I haven't seen this talked about anywhere, but if you think about it, like you have the baby boomer generation, they're called baby boomers, right? Because they had a bunch of kids. They are like, my grandparents are supported by, 5 kids on one hand and 7 on the other. And then, like my kid, I've got 2.
I know.
So if I'm a financial burden to them, like 2 of them have to help me.
Well,
versus
and
7.
My in-laws, my husband is from a family of 6 kids. And when they wwere declining, they all pitched in.
Yep.
It was wonderful. Yep. And I think that's what it's supposed to, we're supposed to be fruitful and multiply. I know. Have more kids.
That'll help you. And there's your financial plan for you. If you're younger, have more kids.
Younger generations are having more kids. My son and his daughter, they have 3 already, and they send the kids to a little school that they're very common to have 4, 5, 6 kids in the families. So have kids, be fruitful and multiply, as they say.
That's right.
Okay, so we're going to talk about how is our system structured. We're talking about the cost and just the high cost, the failure, the services that are provided, the lack of staff, there's just so much. So how is this system it's structured to fail? So that's what I want to talk about. Our senior industry, people want to get on the senior bandwagon because they think they can make all this money. So we've got all these businessmen that are great at stocks and bonds and mergers and acquisitions, and they're going to get into the senior care healthcare industry because they can make so much money.
Well, in their defense, So I like to study economics, and as a hobby. And there's I think his name is Dent. It sounds like a Batman character. It's Harry Dent or Harvey Dent, one of these. And so he's got several books out. He's kind of he's a bit of the the scarecrow, like the sky is falling all the time. So I don't like that aspect of it, but he's got some really smart stuff out there. And he's got one of his books that I have actually tracks the baby boom generation. And if you look at the biggest industries that grew, it was as those baby boomers were growing, and as they were going through toddler years to adolescence to college years and having kids their own. And so a lot of the senior stuff is just following that same trend of there's this big bubble of this population that's aging as they go, and they're just kind of following that.
I know.
So in their defense,
in their defense, I know they see it as money, but it's human beings.
It is.
And as a nurse, I just
formula.
want the very, it is, yeah. I want the very best. So yes, they need to make profits and they need to pay their bills, but they're human beings and we're taking care of our most vulnerable. Mm-hmm. So, anyway, so the senior industry is profitable. These communities, that have all the bells and whistles. There's a community here in Dallas that is $500,000 to move in. That is the move-in cost. Family gets the money back, or 90% when the patient passes or the resident passes. But they have got the furniture is polished. They've got the chef, but really, what's going on with the care? What kind of care are they providing? The building may be beautiful, maybe a high rise, beautiful area of Dallas, but are they providing the right care? Another thing, attorneys, there are attorneys that specifically work with spin downs so that people qualify for Medicaid.
Yep.
So I have had several clients over the years that the family moved the money, hid the money, dispersed, and now mom, who grew up in a very nice home, is in a nursing home on Medicaid with no staff.
There's
pushes
something,
the call light and nobody comes.
Right.
And there is a problem with this picture.
And there's something about like a 5-year look back too. There's some, I remember hearing something about like you can't plan for it today. Like you need to be planning for this like years in the future.
There is,
because I think there's a 5-year look back.
There is,
because they know people are going to play this game.
Yeah, there are ways to work it though.
Yeah,
So I think yes, that money is the children's inheritance, but these adults have saved for this rainy day, and this is that rainy day.
Yeah.
This is that catastrophic time. They need that money for their care.
Yep.
So you never want to jeopardize the care for the savings. Okay. So another thing as far as the SIP system being structured to cost is diseases like Alzheimer's, cardiac disease, dialysis, renal, patients that are diabetic. If you are a brittle diabetic, meaning you need your sugar level checked and you've got to have injections 3 times a day, you don't qualify for most assisted livings.
Right.
If you are diabetic, you cannot move into an assisted living.
Well, we're living longer with a lot more chronic illnesses, and there's so many different dials that are being affected with this that are driving up the cost. But a lot of it's because we live longer and we're getting, we've got these major health issues now, the diabetes, the Alzheimer's, the dementias, all those things cost a ton of money to manage care.
Okay. But
you've
got a patient that spends almost $15,000 a month and you can't check their blood sugar and administer insulin?
Well, that's a care failure piece, but like in terms of like the system itself and how expensive things are, part of the things that work against us is because we have gotten so good in medicine over the last 100 years. I don't know if we've talked about this before, but 200 years ago the average life expectancy was 38.
I know.
100 years ago it was 54. Like good for us. Like we're living longer. The downside is your money has to go longer, and you're probably going to have a lot more chronic illnesses that you're going to have to deal with that are more costly. Mm-hmm. And we have fewer
but
kids.
You know what? I agree with that. But when you're 88, do you really have to have a specialist for cardiology, a specialist for pulmonology, a specialist for endocrinology? Can your general geriatric doctor not handle those things? I think that's what I'm talking about. It is just getting so convoluted.
Well, there's arguments to be made. I don't make them, but you've heard people talking about, the last 6 months of life are the most costly because we're throwing a bunch of stuff at a human body to see how much more can we get out of it, how much longer can we have them live here. And there's a cost analysis that needs to be run. I personally think that's a personal and family decision. I don't think the feds should get involved in that piece of it. But is it worth the additional cost of surgeries or medications or whatever when you've got someone who's in the latter months?
I agree. Agree with you on that. And people do have choices and they have rights, and they have a right to, if they want to have an elective surgery or a surgery that's a 50-50. I'm not sure if this is going to help, but we can try it. Yeah, let's go for it. So, there's just a lot of things to think about. Another thing that is a big problem in our system with these fancy buildings, I'm just using an example, staffing shortages continue to be blamed on COVID. And that is a thorn in my side.
It kind of is. When you throw trillions of dollars at a problem and, the inflation has been real. We all feel it. Like you go to the grocery store. And so, you're the caregiving companies, or whether they're private duty caregiving companies or assisted living. I feel bad. I have friends that own these things. I feel bad for them. Their costs go up.
Oh,
rapidly
astronomical.
Because you're having to compete for, I hate to say the word, but lower skilled labor. That's just frankly what the caregivers usually are, or they're younger in their careers, and so you're having to compete with the local shops down the road or the fast food joints or whatever. And when they're paying $15 an hour, it's really hard to get someone to, because caregiving is a hard job.
It is very hard.
It is very difficult. And so, I feel bad for them because they're having to compete on that front, which just means that the costs get pushed on to the consumers. And so that's why you're seeing these dramatic raises in rent costs or caregiving hours or caregiving costs per hour, over the last few years. So COVID kind of is somewhat to blame. It's really more of our country's response to COVID, but it did have an impact on that.
You're right. So Brian, who is the potential victim of healthcare problems, of this cost?
Who's the potential victim? Well, I think the ultimately, I hate the word victim, but ultimately the person who's most at risk for this is the individual senior themselves and probably their closest family members.
I think it's all of us.
Yeah.
I think we all need to be prepared. I think we need to every family needs to have this conversation.
It's interesting you said, yes, I agree. It's interesting you said that. When I pull this chart real quick. There was a thing, because I don't want to misquote. They looked at, here it is. This was done by a group that uses sensor technology in homes. And so I guess they did a bunch of studies. I don't think that this was their study. So they don't state who actually came up with the study. They just say a group of studies. By some estimates, states, because the Medicaid stuff is not done at the federal level, it's done at the state level. States can save an average of $9 million per day in healthcare costs by making it possible for just 10% of their elderly population to remain in their homes for an additional 1 to 2 years.
Wow.
So there could be an argument to be made at the state level that having some sort of additional funding. Again, it's not the Medicaid side that we're most concerned about, because there's already the safety net for them. It's really the middle income folks. And by the way, here in Dallas, I know that the Medicaid beds there's a wait list.
Oh,
and so now what am I doing when I'm waiting? So the people who are most at risk are like the middle income folks. And so there's an argument to be made of, can we do something at the state level if it's going to end up being pushed to the state taxpayers anyway? If we can save, $9 million per day just by taking care of the 10% and keeping them in their homes for another year or two, what's that look like?
I think that sounds good.
So in that end, we're all kind of at risk for, I don't know, it's mismanagement. I think it's happened over time. I think you could see the silver tsunami happening, because we saw the baby boomers aging or whatever. And I just think, we as Americans, we're just not really good planners.
I think we're selfish too.
Yeah.
Americans are selfish. I just got back from Europe and had a wonderful time. And just what I loved over there is life is just simpler over there.
Yeah.
And I think we have so much as Americans, we supersize everything.
We do.
And sometimes we just need to get back to basics and simple and being kind to one another. Bring your neighbor who's been in the hospital a casserole. We don't do that anymore. Dallas, Texas, we don't.
Yeah.
So I just think we need to take care of each other, and we need to take care of our loved ones. And
we need to start having these conversations as family members way before it's time. Mm-hmm. If your parents are in their 60s and 70s, before they start having those, catastrophic illnesses or whatever, or the dementias are setting in or whatever, like this is the time to start having those conversations so that everyone's prepared of, okay, what kind of assets are we dealing with? How many kids we got? What are their assets? Like who can mom or dad come live with one of us? Start having those conversations now. Cause as well as I do, most of the time this stuff happens, it's in crisis mode.
It's absolutely crisis.
It happens
and they have
all
no
of a sudden.
idea what to do.
That's right. And now everyone's making decisions, long-term decisions with a very short time frame to deal with, to make those decisions on. Mm-hmm. Limited information and limited time frame. Mm-hmm. And stress, not a really good combination.
That's why they should hire a nurse navigator.
That's right.
Yes,
I know one.
We help. I know we help in those crises. So we're gonna do a couple of case studies and just briefly talk about. Or would you have time for two?
One or two, yeah.
Okay.
Yeah.
So we're going to talk about a client of mine right now, Jim. So I'm just going to talk a little bit about Jim and telling you his situation and how do we handle this. So Jim is an 80-year-old recently widowed male. He was a veteran, served in Vietnam. He falls. He has chronic cardiac and lung issues, heavy smoker, heavy drinker. He is dependent on oxygen, no longer smokes. He worked until he was 65, but took out after 65, still continued living like he still had a paycheck and wound up taking out 2 reverse mortgages on his home. Ooh. So right now he lives in Dallas, but if he were to sell his home tomorrow, he would not make, but probably $50,000 to $75,000. Everything needs to go back to the bank. But he wants to stay at home. He's fallen. Mm-hmm. He's been in rehab. He's in rehab right now. He paid an expert to help him with VA benefits.
Good.
But 5 months later, we haven't heard anything. So,
so we can connect him to our mutual friend, Eric.
Okay. That would be awesome.
There is a bridge company who, while you're waiting for Medicare, I'm so glad we had him on the show a couple episodes ago.
I missed that week.
There is a bridge company where you need care now. And while the application process is going on, they will actually fund your care.
That's awesome.
You pay them a small percentage ongoing, but you don't have to wait like the 6-month time.
That's awesome. That's all. Well,
so
we'll talk
with Eric. Yeah.
So right now he's in rehab. He has had no therapy for 1 week. So I marched up to that nurse's office and therapy office, and he did get therapy today. But he wants to go home and he has no money for caregivers. So he did find out that he will be reimbursed if he pays for caregivers, but we don't know when that will be because we don't know about the VA. Right. He will qualify. Yep. But anyway, everything's in the unknown. So he doesn't want to hire caregivers. He really doesn't have the money. He doesn't want to move in with his daughter. She's got 4 dogs, 3 kids, and he's fallen already. How would you, and I love you said that answer, finding about that bridge program.
Yep.
What else would you suggest?
So as a therapist, I would look at what are the reasons why he doesn't feel like he would be safe at home? Is it because of the falls?
Because of the falls, and he drinks by himself.
Okay. Well, so some of this is going to be a behavioral modification for him, right? So if we're having falls, like we need to be avoiding things that are going to contribute to that. So I would definitely have a home safety assessment done to see what else do we need to be doing in this home to make this place safer. It could be rearranging furniture. It could be getting rid of some furniture. It could be raising furniture, lowering furniture. How accessible are the bathrooms and the tubs and the toilets, a number of different things. Like we look at 68 different things when we're at home.
And
to make
Wipe Alert too. So
yes,
we've gotten that ordered.
Yeah. So I would first and foremost look to see what things when I say assets, I mean like what assets in terms of human assets that we have access to, what assets, like what does the actual home asset look like? What's the equipment situation look like what kind of equipment does he have? Does he need? There's a lot of things that you can do to shore up somebody in their home to keep them there a little bit longer without a ton of need for the private duty. At some point, like you're going to need caregiver help. But if he's with it and it's just a matter of it's a functional safety issue and maybe some behavioral modifications with the drinking piece, like if you want to drink, fine, but drink in bed, right? And, have a urinal or something. So there's a lot in there. There's a lot of variables to look at. I would say the first thing to do with him though, is get him connected with Eric and see what we can do on that piece of it. Because they may be able to get some caregiver help right off the bat.
That's awesome.
Or go live with your daughter for a few weeks while you rehab a little bit further to make it a little bit safer for you to go home.
And I recommended that too.
There's a number of different ways. And so, we're really careful when we work with patients of ours that I'm not here to tell you what to do. My job is to lay out, hey, here's what we're dealing with. Here's options of all these things that we can look at. And then I'll help guide you through the process on what do we need to do to make this environment safer for you. But I'm not in there to rip out rugs, and I don't do demolition stuff myself. But we make the recommendations and try to figure out what's going to fit your lifestyle.
I love that. And that can keep him in his home.
Right.
That's great. Do you have a case study we could talk about?
We have them all the time.
Yeah.
We have a recent one where it's kind of a sad case. The mother had a stroke early, like young. I think she's in her 50s. And her oldest daughter, I think, is 22 or 23. And then I think there are two other siblings. And so the older daughter, who's very young herself and still, she's not wise enough. She hasn't been on the planet long enough to really be wise. So she has no idea how to navigate all this stuff for her mom. But her mom is almost complete dependent on her daughter, who also, by the way, has to raise two smaller kids. And, this is one of those scenarios where it probably was not foreseen. Like, who's going to expect somebody in their 50s to have a stroke like this? But this is another one of those scenarios where there's clearly not money, and so we're having to get them connected with social services and those kind of things to help put some pieces in place for them, because this is a hard situation.
Wow. I would recommend, a lot of the churches now are doing adult daycares, and they're like a Mother's Day out, when our kids were little, but they're a mom's day out or a daughter's day out.
I've seen that before too. And
a lot of churches know the need, these people that are in that are not poor and not rich. So they're right in the middle. But that's what I would do, is try to find some kind of adult day program.
We're doing that too. Yeah.
And then how her home, is that paid for?
No, they rent.
Oh, wow.
There's no assets. Yeah.
There are the low income, 50 plus apartment complexes. And I've had residents patients that have lived in those, and I've been very
they're nice. There's several of them around here. The Evergreen properties here are really nice. Yeah.
Now the young kids couldn't live there,
right.
The daughter and the young kids, but
they don't have any money for caregivers. Like, she is the caregiver.
Wow.
Yeah. So
how old are the children?
Young. I wasn't the therapist on the case, but they're significantly younger than the older daughter.
Oh, wow.
Yeah. So again, another one of these, we see them all the time. You and I have a mutual client that we worked with that, he had assets that were paid off, but had no cash flow coming in. And so trying to figure out how to navigate that kind of stuff and figuring out, okay, what do we actually have that we can work with here? A lot of that went through, we reconnected him with a family member who had been in his life, but not as much in his life. And so he needed that to help navigate some other things. And so he's on a much better path now.
I'm so glad.
Yeah.
That's good to hear that.
Yep.
Well, Brian, thank you so much. I think that the takeaway here is communicate with your family. What are your wishes?
Beforehand.
And, it should be a conversation where I'm sure you're already talking about with your high schooler, where does he want to go to college?
Mm-hmm.
That's a normal conversation for a high school student and their parents. You know what? It should be a normal conversation when an adult turns 50. Mom, Dad, we need to know what your wishes are going to be.
Right.
You never know what tomorrow's going to bring.
Well, a lot of people will have, they've got long-term care, not long-term. Let me rephrase that. They have like the wills and trusts set up in the event of their eventual passing, but not a lot of people are setting up things for, before then. Like, where do I want to go? Do I want to live in my own home as long as I can? Okay, what does that look like? What's the cost look like? Or are you okay moving to an assisted living or memory care facility or what have you? And what does that cost look like? What assets do we have to be able to pay for that? Can family members help? Like, all those things need to be discussed way before, because the last thing you want to be doing is in the middle of a crisis having to figure that piece out, which is what we see all the time.
I know this sounds crazy and people think, I don't want to tour a community, but tour a community. Have a conversation with your 50-year-old parents, 60-year-old parents. Just look what's out there. Look at the cost.
There's some beautiful ones out there.
There's some wonderful ones. It's real funny though, because I've been going with this particular client to look at places, and they all kind of say the same thing. So I think they're keywords that they say.
There's industry jargon.
Yeah.
We all have it. Yeah,
I know. And I'm like, please don't say that again, because she's already heard it every time. And let's do something unique.
You sound like the last place we went to. Yeah.
I know, terrible. But anyway, so just be prepared, just have that conversation and be willing to help. If you do have the means, everything is costing more. And so if a family member has the means, help,
right.
So thank you so much. This was great. Dying broke, it's just such an important conversation. It's very sad, but it's reality.
That's right.
Anyway,
thanks, Joe.
Thank you, Brian.
All right, see you next time.
Sounds good.
Right,
you have
bye.
a great day.
Thank you.